Hi, everyone. We're going to give it a moment or two before we start, but we are happy to see you here. Feel free to introduce yourself in the chat. We'd love to know who is here, where you're coming from, what your roles are. Feel free to do that. We're going to have lines muted, but you're welcome to utilize the chat, ask questions in the Q&A. We'd love to hear from you today. Again, we'll give it probably another 30 seconds to a minute to start. Thanks, folks, for introducing yourself. We appreciate that. Yes, good afternoon and good morning, depending on your time zone. Lots of represented time zones here today, which is fantastic. All right, I think for the sake of time, we will go ahead and get started. So again, hello and welcome to this session of our Diabetes in Special and Vulnerable Populations National Learning Series. This is the third of 4 sessions in this fall's National Learning Series. Today, we are focused on emergency preparedness for diabetes management. This is across the diabetes continuum of care. All 4 sessions are focused on this, and we have different subtopics. So again, hello and welcome. We are so glad you're here. We can go to the next slide. Lots of folks introducing themselves, which is so fantastic. And yes, the session is being recorded. Thank you for that question. So I will not read all this text on the slide, but this is just background information for you. If you are not already familiar with our diabetes task force, there is a group of 14 national training and technical assistance partners, our NTAPs. Our organizations have worked together for several years now to every year hold this National Learning Series where we're focused on diabetes and chronic conditions and the impact on a lot of these at-risk and under-resourced patient populations. We try to take feedback every year, see what the priority areas are for you, the audience, as you're caring for patients living with diabetes or at risk for diabetes, and try to construct a learning series that's really going to meet your needs. So we are really excited again to continue this. And I think we have another slide next that shows, yes, our partners. These are the 14 organizations that I've mentioned. We have a wonderful website, chcdiabetes.org, that contains recordings of past National Learning Series. If you're interested in watching those, we'll have the recordings and the slides up from this whole series there as well. And if you're interested in learning about any of these partner organizations, all of our links are on that website. You can go to the next slide. And yes, like I mentioned, this is the third of 4 webinars in the National Learning Series. You can see that we have a final webinar this Thursday on environmental impacts on diabetes access to care. I think I just saw, yes, thank you, Kara, for the link to register for that final session. If you're interested, we'd love to see you there. And again, if you weren't able to join us for webinars 1 and 2, the recordings should be up on our website soon. You can go to the next slide. Certainly conflict of interest disclosure. No one participating in this session today has any interests that are, related to the items you see on the screen: pharmaceutical companies, biomedical device manufacturers, or others that are pertinent to this topic. We can go ahead to the next slide. We are able to offer very select continuing education credits for this webinar session, CNE. If you are interested in this credit, we will have some information on the evaluation, I believe, and there's a couple of points of contact at Migrant Clinicians Network who's providing this accreditation for the CNE. If you have questions, again, I believe the evaluation link has that information. If you would like credit, CNE specifically for this session, you'll need to fill out the evaluation, and then you will receive more information on when to expect to receive the credit. We can go to the next slide. All right, great. So this session in particular, 3 of the 14 NTAPs came together to put this session in place. You can see we have representatives from the National Center for Health and Public Housing, Dr. Jose Leon. We have Flor Robertson from MHP Salud. We have myself and Juliette Provost from the National Center for Equitable Care for Elders. So we each have unique patient populations of focus. I think we'll end up touching on them a little bit in this session, though the overarching focus is really all at-risk and underserved patient populations that are a focus of the Diabetes Task Force as a whole. So big thanks to the moderators and organizers. You have seen these learning objectives since you signed up for this session, but we are hoping you walk away from this webinar really understanding better some of the barriers that patients may have when they're living with diabetes for effective emergency preparedness. We have a really interesting representation in our panel, which I'll get to in a moment, location and climate. So we'll learn about some of those unique barriers. We'll talk about the way that health center staff are engaging with patients related to ongoing diabetes self-management, and then hopefully send you back with some resources around diabetes during emergencies, whether that's checklists, disaster supply kits, potentially other resources. So this is what we're hoping you walk away from this webinar today with. You can go ahead, next slide. Great, so we have three fantastic panelists. We have some introductory content from each of them. What I'm going to do is read abbreviated bios for each of them, but they are welcome to further introduce themselves during their presented material. What we'll do is hear a little bit more about them and their health center or primary care association, and then we'll move into a facilitated panel discussion where we have some curated questions for our panelists to engage with, and we would love to hear from you as well. This is already a really involved group. I see a lot of great introductions, so I really hope you'll bring some questions and feedback to the table. So feel free again to use the chat box and Q&A feature throughout. So again, I'm going to briefly read abbreviated bios, but would love to hear more from our panelists as we go forward. So our first panelist is Eunice Hines, who's the Director for Migrant Health Services and Outreach at the Community Health of South Florida Incorporated. During her 15-year tenure at CHI, she's concentrated her efforts on serving at-risk populations by leading and coordinating various evidence-based programs focused on chronic disease, self-management workshops, and the effective recovery of at-risk patients. She's also facilitated annual cultural competence trainings for staff as they aid medically underserved communities. Our second panelist is Dr. Silkia Iritzari Martinez. She's the Continuous Quality Improvement Program Director at the MedCentro Healthcare System in Ponce, Puerto Rico. Since 2010, her focus has been creating and maintaining the clinical quality program for the institution. And our third panelist is Ivan Prado, who joined the California Primary Care Association in September 2021 as their program coordinator of health center operations. He's the lead content lead in emergency management efforts and serves as CPCA's point of contact for emergencies. He joined the Primary Care Association after 8 years of working with nonprofit organizations and FQHCs in the Central Valley. Throughout his career, he has successfully managed several programs and projects focused on improving the health and well-being of vulnerable communities while ensuring access to health. So again, we have a fantastic panel. What we'll have for the next 15, 20 minutes or so is introductions from all of them around their the background of their locations, a little more information about diabetes management and emergencies. So Eunice will be first. We'll have Cindy advance the slides, and we're really looking forward to hearing from our panel. Take it away, Eunice.
Good afternoon. Thank you, Ariel, for that introduction. My name is Eunice Hines, and I have been with Community Health of South Florida, located in Miami, Miami-Dade, and Monroe counties for about 15 plus years. I am a certified CHW, so my core functions are of a CHW, and I focus on reducing social determinants of health. Next slide. Our mission is to deliver safe and accessible, compassionate, and culturally competent quality healthcare services to the people of South Florida while training the next generation of healthcare professionals. CHI is also a teaching health center for primary care and behavioral health. Our vision is to become a healthcare provider of choice for the people of South Florida and a teaching center of excellence for healthcare professionals. Next slide, please. Our motto is patient care comes first, so everything that we do focuses on patient care, and our focus is to reduce barriers of care. Services sites are, as you see in the slides, there are many. Right now, we are renovating the one that's in Coconut Grove. Our newest one is the one in Key West, Mile March Zero. Yes, just like that at the bottom of South Florida. Next slide. And that is 12 federally qualified health centers, 9 in Miami-Dade and 3 in Monroe County. We are also in over 35 school-based clinics, and we have 2 mobile units, one dental and the other one is primary behavioral health services, and that's the one that I oversee. Next slide, please. Our services include primary care, pediatrics, behavioral health, psychiatry and mental health, good crisis intervention unit, dental, diagnostic lab, diagnostic radiology, OBGYN, intrapartum care, optometry, pharmaceutical services and delivery, LifeScan fingerprint services, telehealth, translation, transportation, urgent care, and walk-in services. And of course, CHI being a federally qualified health center, we have facilities that are geographically located in South Miami-Dade and Monroe counties, areas subject to natural disasters such as hurricanes, tropical storms, and flooding, as well as man-made disasters. CHI may be called upon to provide emergency patient care in the event of disasters or a major accident which occurs within CHI service areas. It is our responsibility or the responsibility of the President and CEO to call upon our COOP, what we call the CHI Continuity of Operations Plans. And this COOP is done in coordination with the Miami-Dade County and Monroe County and also the state of Florida Governmental Emergencies Management Agencies. And this plan covers all CHI sites and business locations. The Environmental Care Committee also serves to review all emergency management procedures, and this plan, COOP, and related protocols for the organization as a whole. It provides guidance for implementation of emergency procedures prior to a declared or imminent incident and immediately after a disaster in order to ensure optimal medical care for patients while maintaining the safety of CHI's employees and security of its facilities and equipment. Now, we do get a lot of hurricanes between the time of June and the end of November, so we really rely on COOP to be able to provide services to all of our populations and be operational even through all these natural disasters. I believe that's it, right? Yes. And that is my contact information. Thank you.
Great, thank you. We can go to the next slide and we'll go to Dr. Zolkia.
Hi, everybody. Good morning and good evening, good afternoon. Here in Puerto Rico, it's 3 o'clock in the afternoon. Can you pass the slides, please? Med Central Healthcare System was founded in 1971 by a group of Ponce citizens, and Sister Isolina Ferrer. She was a well-known here in the area of Ponce, who dedicated her life to improve the community of La Playa de Ponce, but now we serve a lot of the south part of the island. Since the beginning of the organization, it's been part of the federal government health system for primary healthcare system services. It's a federal qualified health center. It is currently integrated by approximately 464 employees. The majority are healthcare professionals who serve a population of 44,000 patients. This is the data that we have from the relevant system in our data source. Med Central Healthcare System distinguishes itself from other primary healthcare centers because of its excellence in quality medical services and great variety of clinical service with easy access and personalized and kind manner with the patient. Next, please. The institution is a non-profit institution, and the board of directors is constituted by patients receiving medical service at the clinic. They also represent the community around the center. This explains why at the Central Healthcare System, the patients are and always will be our #1 priority. As a learning health institution nationwide, You have an obligation to follow the strictest quality standard when providing integral primary health services for all the population. Consequently, in participating in a large number of clinical programs for a special population, including the Reform Health in Puerto Rico. It also receives self-pay patients and the majority of private healthcare insurance plans containing the most complete offering in healthcare services. We have a center along all the south part area of Puerto Rico. We also have 4 mobile units that we, since the beginning of our hurricane, earthquakes, and pandemics, we've been using a lot. Next, please. This is a background information so you can see how we are. This is the data, updated data until a week ago. Non-insured patient to 3.2%, Medicaid 70%, Medicare 14.3%, private insurance patient does 12.5%. This is the gender distribution. Male 57%, female 42%. Next, please. This is the patient income and perception of poverty guidelines. The majority of our patients are under or below the 100%, is the 54%. Next, please. This is the special population that we serve: migrant or foreign seasonal workers, 1%, homeless, 5.3%, school-based program. We serve like 5 schools in Ponce area and 2 in Villalba, it's another town next to Ponce. The veterans, and this is other service that we provide. This is the clinical service program, case OBG and gynecology, pediatrics, general medicine, family medicine, internal and chronic condition clinic, dental clinic, psychiatry or behavioral health clinic, where we have psychologists and psychiatry, urgency room services in Ponce, emergency room service in Peñuela, ambulatory services, surgery, ancillary services. We have a diagnostic laboratory, we have pharmacy, excuse me. We have pharmacy, diagnostic images, diagnostic exam, complementary program. We have a nutritional program, a family planning program, health certificate program, outreach program. We are patient service patient center medical home level 3 certified, patient education program, social workers, MTM program for diabetic patients specifically. Diabetic care collaborative, we have 2 programs, one in the chronic clinic and one in the family clinic. Case manager, next. That's also a special program that we serve, the Preparedness program for HIV/AIDS patients, the migrant and the school-based. We have medical services, dental services for public housing, all the public housing services we give in the mobile units. Also, we go to the farms in the mobile units to give the medical services. We have extended our services and home life program service. Next, please. This is our population with diabetes. You know, I don't know if you don't know, but in Puerto Rico, the prevalence of the diabetes is very high. We have 50.8%. Every 2 of 13 people in Puerto Rico have diabetes. So it's in the Latin community is very prevalent. The diabetes is a problem here. It's almost a pandemic that we have to be managing. And now that our patients are becoming, or this baby boomer are becoming older, they are the majority of our patients and they are diabetic. We have a total patient with diabetes in our clinic, 4,790. We have a total patient with diabetes type 2, 4,236, and with type 2 uncontrolled, we have 46%. So it's high. We're working with the season. This has been happening since like 2017. This is the tendency that we have been observing since we start with Maria, the hurricane. I don't know if you remember in 2017. Here in Puerto Rico, then our diabetic patients start to go down in the control. Next. Thank you.
Thank you so much. And our third panelist, Ivan, will take it away.
Hello, everyone. My name is Ivan Prado, Program Coordinator of Health Center Operations at the California Primary Care Association. Our office is located in Sacramento, California. Next slide, please. So our mission is to lead and position community clinics, health centers, and networks through advocacy, education, and services as key players in the healthcare delivery system to improve the health status of their communities. We represent over 1,300 community health centers here in California, which provide high quality care to over 7.2 million people each year. I work in the emergency management department, and so some of our priorities revolve around advocacy, CMS, emergency preparedness, rule compliance, training and technical assistance, internal emergency activation, and public health emergencies. We really want to advocate for that community health centers are key partners in emergency response efforts. And that they play a critical role in making sure that patients receive appropriate levels of care. We saw this particularly during this time of COVID, and still right now with the current surge in respiratory illnesses, helping out the surge of patients in the hospitals, and so really making sure that we're able to take some of that off of them and continue to treat patients at community health centers. Some other advocacy has been around wildfires. As I know, I'm sure many of you have heard, there's a lot of wildfires impacting different parts of California throughout the year. And so that's been another thing that we've been focusing on. Next slide, please. So again, some of the other emergencies that have been impacting California also include air quality stemming from wildfires. So with all the smoke, this impacts the air quality. We've had health centers have to close down at times that there are wildfires in the area due to the air quality. Extreme heat. This year we saw record temperatures. With that, people are using their air conditioning more than usual, which is draining the electrical grid, and so that also leads to power outages, whether it's to conserve power or sometimes due to extreme weather. There are areas of California that have high wind areas. And so in those areas, sometimes there are public safety power shutoffs. So during the time of high winds, they turn off the power to prevent wildfires due to electrical poles falling over and causing wildfires. And we're still in COVID's public health emergency. And like I mentioned, responding to the current increase in respiratory illnesses with RSV and the flu. Some of our national partners include HRSA and NAC, and then emergency response partners, AmeriCare's Healthcare Ready and Direct Relief, all provide medications, medical supplies, and sometimes cash grants in times of emergencies. And so they've really been a great help for health centers throughout California in times of emergencies, and especially around wildfires. Collective Energy Company is another organization helping health centers be able to access backup power and solar power at their sites. And then we work closely with the Emergency Management Advisory Coalition, which is made up of primary care associations throughout the country, where we share different resources available to health centers. Next slide. I think that's it. Yeah.
Great. Thank you so much to all of our panelists. I'm seeing we have a question in the Q&A that we're going to partially answer, I think, through this panel discussion, and then we'll circle back specifically to another part of your question, Gladys. So that does give me a great reminder for folks to definitely continue to engage with our panelists in the chat and in the Q&A. We're going to have a few questions that we've prepared already, but that's certainly not all of the questions that could be asked of these panelists. And as you heard through their introductions, they're coming from different states, territories, locations that may be impacted differently when emergencies happen, and certainly the past few years have had their fair share of different emergencies for their patients to navigate. So we'll go through some of these prepared questions. We'll go in the order of the panelist introductions just to keep it straightforward. But again, at any time, feel free to add in your own questions from the audience in the chat or the Q&A, and we will circle back to them. So let's go to the next slide. We have our first question, and it's about barriers. So it's kind of a two-part question. When we're thinking about your patients, whether that's at your health centers or for the PCA for your state's health centers, curious about what they experience barrier-wise to diabetes self-management outside of an emergency. So just in general, what are some barriers that your patients experience? And then the follow-up question is really, how have either natural disasters or public health emergencies impacted those barriers? You assume most of the time that would be even more of a negative impact, so intensifying a barrier. If there's any different impact, would love to know that as well. I think that Eunice has a couple of slides prepared for her answer, so we can go to the next slide, and Eunice can take that question first. And thank you. Yeah, I do see someone responding their own patient barrier, so would love to hear from the audience as well. So Eunice, take it away with this question.
Thank you. So what barriers do patients in your health center experience related to diabetes self-management? So when it comes to natural disasters, of course, all kinds of protocols just go out the window, especially for each individual, all of our patients. We have about 77,000 unduplicated patients as of the UDS for 2021. Only 12% are diabetic. So what happens is that there is an ability to get medications, the inability to control their stress levels, which also produces, much more restraint to their comorbidity illnesses, the food shortages, and then worried about losing their home, of course, because we are, like I said, prone in areas where we are going to get hit, whether from hurricanes or floods and other man-made disasters.
Great, and we can go to the next slide. Cindy, I think there's the part two for Eunice.
Sure. So how have natural disasters, public health emergencies impacted these barriers? We noticed that we need to incorporate some chronic disease self-management program workshops for our patients and their caregivers, which helps them, what to do, how to prepare for not only diabetes, but any other chronic health condition. And here, they learn to do action plans, to learn how to exercise for their, to reduce, their high blood pressure or their glucose. They learn to self-manage the stress, just basically make a plan for themselves when it comes to medication. We have had to expand our hours of operation at our centers. We've had to aggressively do medication delivery programs. So before we only had one car, now we have another type of third agency that does this for us. So we kind of got savvy with that medication assistance program as well. Before it was one outreach worker for all of these centers. Now we have basically a specialist that does this at each of our pharmacies. We basically have had to do telehealth, not only for behavioral health services, but for all other primary care services. We have actually assigned a community health worker. We have a max of at least 3 at each of our centers. And of course, before we used to, when it was time for hurricanes, it was just a matter of us monitoring the trail of this hurricane and bringing in all the medications to our main site. Well, now we don't have to worry about that and the whole running around. We're more like we have a janitor at each site that's able to help us out with the medications and vaccinations and such. One way that we communicate with our patients is either through, I think I'm ahead, but I do want to share that now. It's either through my chart, or we have this platform called Solutions Reach. So we send them texts. Do we want to go there? Do we want to go to this side, or do we go to the slide?
We'll-
Or what?
We'll,
No?
we'll
Okay,
come,
okay.
we'll focus on it in more detail in a little bit, but
Okay.
yeah, it's fine to touch on it now. Yeah, for sure.
All right, thank you.
All right, great. Can we go back, Cindy, just to the first question slide? Thank you. Dr. Zilkia, do you want to speak to this question?
Yes, absolutely. You know, in Puerto Rico since 2017, we've been experiencing a lot of natural disaster. We started in 2017 with Maria, that we did have 1 week for preparation, but we didn't expect that the government won't respond the way we expected. So we have to take care of everybody, even there wasn't our patient. We have to give the medical services because most of the clinical services were closed. People left the island in Maria, so we have to even give them food, water. We have an area that we prepare with a fridge because we did have already the electricity, the generators in all of our centers. We have generator, so we can provide places for the patient to put the insulin, so we can take care of that for them. The week before the hurricane, we developed a program with a task force where we give prescription for 90 days of medication to the patient. And the insulin, we keep it here and they come to the center. If they don't have transportation, we give them the transportation. We learn a lot in that period because at least my generation, we didn't work with hurricane or any of disaster. So it was the first time the majority of the clinical people here have to confront that and work it. And we learned a lot. The barriers for the patient were malinformation. We didn't have electricity. We didn't have water. We don't have a way to communicate because we didn't have telephone. We lost all the cell phones for like 3 weeks. And the south part of the island, it was the worst. We received the most damage in all of the disaster in the hurricane in both in Maria and Fiona in last September. The south part of the island is the one who was worse. For Maria, we have I don't know how you say, we work with, how you call it, direct relief. So they provide us with better transportation so we can get to the area that where we lost highways, we lost way to contact the patient. We have to go walking on the by foot, all our outreachers to go to the patient. That was the first time that have to be done from at least in this part of the island. Another problem was the food storage, and we also give food to the patient. They don't have to be our patient. Anyone who come here, they will receive the help. That doesn't matter. And the other part of the question, how the emergency impacted our body, where in our staff, our clinical staff, we have 44 of our staff that lost their homes during the hurricane. And you know what? The next day, they were here working. And that's, we learned that the compromise that we have for serving the underserved, it was spectacular. Do you have any questions?
Thank you for that. All right, we'll have Ivan answer this, and then we'll move forward.
Yeah, so some of the barriers that some of our health centers have shared are a knowledge deficit, just with the complicated medical regimens and like the expectations of care plans with the visits, medications, physical activity. Sometimes it's a lot for patients to understand. And so it's important for health center staff to be able to provide the education at a level that they understand, and especially in their native language. There are other financial barriers, and either due to lack of insurance or underinsured. especially with like frequent follow-up visits, monitoring supplies, medications. They've shared that patients sometimes are sharing their medication or rationing it because of barriers in financial barriers. Fear, a lot of patients with fear of needles or performing finger sticks or injecting insulin. Ostrich syndrome. Sometimes everything is so overwhelming with their diagnosis and the needed changes in their lifestyle that sometimes it leads them to just kind of ignore the condition and not necessarily attend and follow up with those necessary visits. And another huge barrier is transportation, especially those living in rural parts of the state where a community health center can be miles away. During natural disasters or public health emergencies, some of the things like, especially like during wildfires, is being separated from their medication or having a lack of refrigeration when evacuations and relocations occur. Sometimes you're in a rush to get out and you don't have time to pick up your medication. And so figuring out how to get access to it. This also leads to high levels of stress, depression, and anxiety. This was especially seen during the COVID lockdowns with just depression and just isolation. Something that has helped is the telehealth access, but that's also requires a reliable internet connection or access to computers or smartphones. And so we recognize that there are patients that don't have access to all of that, but we have seen an increase in care due to those that access. Also during the time of COVID, just patients avoiding personal appointments or in-person appointments due to fear of transmissions or infections. And then another big thing during disasters is staffing. So again, staff is part of our communities, and so sometimes they are impacted themselves, whether they're having to be evacuated because of wildfire, so they have to leave work to go get their kids or evacuate their families, or them road closures, or they themselves being sick or taking care of sick children, sick family members. And so staffing really affects the number of appointments available for patients during these times.
Great, thank you. And I know that we had several folks in the chat share about the experience that their patients have had with barriers both during and either before or after emergencies. So we're really appreciative of you sharing a lot of those difficulties. I hear those echoed through some of the panelist responses and see that we're getting some questions related to some of those barriers, and we'll see how much time we have at the end to circle back to maybe some brainstorming around that. So let's go past yep, these two. All right, great. Our second question for our panelists is around communications. I heard a little bit from the panelists on this, but we'll focus a little bit more on how patients are really engaged by your health centers before, during, and after emergencies. And depending on your role or your setting, how do enabling services staff play a role in these efforts? Would love to hear more about that from our panelists. And I think that we have a few slides again from Eunice, so we'll start with her. We can go to the next slide.
Okay, so how does your health centers communicate with at-risk patients populations about emergencies before, during, and after an event? So we have care coordinators assigned to patients, and they do follow up. And of course, these care coordinators have this type of family bond with these patients. And so they're always in communication on how to manage their conditions. And they're always, there with the communicating part. They're always on point with that. We also have a platform called Solutions to Reach platform, which is like a text-based type of communication with all of our patients. And like I said, we have over 77,000. We have social media, of course, there's always communication on where they should go if one of the sites are closed, what to do in case they cannot get a hold of their doctor, who to reach if they cannot get a hold of their doctor. My chart is also another way of communicating with our patients, especially with the doctor and the patient, uh, I guess, contact during medical visits. Of course, they speak on that. They talk about that. Then we have the medical mobile van, who goes to hard to reach locations in public housings, migrant communities, and the homeless encampments, and provides primary care services and behavioral health services to the population of residents of the community. And we also conduct home visits. Outreach conducts home visits, sometimes with the care coordinators, to assist families or patients that have been lost to care, or do not have the possibility of doing telehealth. Uh, and so we are able to tap in. Now, to answer the second part, which was what role does enabling services staff play in these efforts? Is that the second
Yep,
part?
we can go to the
Your
next slide.
question?
Eunice, your audio is
Okay.
breaking up a little, but I started to hear you better. So I'm gonna have my
Okay.
fingers crossed.
I'm gonna get there. Oh my goodness. All right, so what role does enabling services staff play in these efforts? So our community health workers have a lot of roles. They have a lot of very interesting resources. Not only do they have resources of their own, but they come in through grants. So there's numbers that they need to meet, but the resources are within the community. They'll link them, they'll assess them with the social determinants of health. We have transportation that we able to provide transportation to and from our health centers to the participants. We address the social determinants of health, which addresses transportation, level of stress, their safety, food, education. There's always education upon whenever the CHW touches a person, a resident, there's always some type of education. Referral linkage is also there. Locating these patients lost to care when they do home visits. And I've also developed relationships with local community-based organizations and churches is a must when it comes to enabling services.
Great, thank you. I have a follow-up question for later on the partnerships. All right, Cindy, can we go back to the question slide? Great. Dr. Silkia, do you want to answer for this one?
Yes, also your health center communicate with at-risk patients. Well, for hurricanes, we can prepare because at least we have 1 week before the disaster come to us. But for example, in the south part of the island, in January 2019, we start with the COVID pandemic, and in January 2020, we have earthquakes here in the south part of the island. So since that you cannot prepare, we use the mobile unit and we move to where our patients are. We communicate by the radio, education, always education, and all of the service that we provide. We have a staff specifically for emergency. So they are integrated from all of the clinic, even people that are not clinical staff. They've been there working, helping with the patient and coordinating the care of the patient. When we can prepare, we give prescription for the patient for 90 days. When we cannot prepare, we open our services, our pharmacies, we never close. And since the pandemic, we start using the telehealth. We have the system for like 5 years and we never use it. And due COVID, we start to use it and we love it and patients like it. Even patients that are 55 or older, they do have it. The problem we have here is the stability of the internet. That's a problem on the island sometimes, that when we don't have power, we don't have internet. So that's one of our problems.
Great, thank you. And Ivan, what are your thoughts on this around patient communication?
So some of the things that health centers leverage from California is the patient portal. which can send mass text messages or emails and social media. We're acknowledging that not everyone has access to these mediums and internet, but they've shared that this is the way that they're able to reach the highest number of patients in times of emergencies. And then as far as enabling services, transportation is something that they really help with, and which can be enhanced during and after emergencies and disasters, and also helping with telephonic outreach to identified or high risk patients that they've identified.
Great, thank you. All right, we'll go ahead to our final prepared question. So we'll go, yep, fantastic. All right, so this is really focused on resources. So knowing that all of our panelists are coming from different states or territories, curious around what types of resources are available for your patients, if it's local, if it's federal level, state level information, certainly in general, but we are, since this is a diabetes focused task force and learning series, curious about any specific diabetes resources that you're able to offer patients in regards to emergency preparedness. So we can go just to the next slide because Eunice has a list for us. So we'll have her take it away first.
So what emergency preparedness resources are available in your state territory for patients living with or at risk for diabetes? We have Community Emergency Response Team. It's a team of volunteers that are trained in basic response skills that go door to door, and they assess and identify those in need of assistance after disaster. We have shelters, that are available for families and their pets. And of course, that's a beautiful thing, to have their pets, because that's part of their family as well. And a lot of those, families depend on their pets for emotional support. We have the FQHC, which will be CHI, for instance, to provide medical behavioral health services with pharmacy open, labs, urgent care, and crisis unit that addresses social needs and linkage. So we're one-stop shop. We have Americas, and Americas is a very good company. I've also provided the link there. We provide supplies and medication free to organizations during natural disasters and events. So we also depend on them more because of the supplies. In the Department of Health and Resource and Education, which provides education and linkage during these times.
Great, thank you. Let's go back to the question slide, Cindy, if we can. Oh yeah, we have some extra stuff. Great. Dr. Zilkia, do you want to mention anything about resources specifically for your patients?
Yes, I can talk a little bit. Our state, our government, Puerto Rico is not a state, but it's part of the United States. We depending most of the time from the federal government help. But for example, in the hurricanes, the local government never respond correctly. Sometimes the federal government start helping us before our own government. But at least in the south part of the island, we have a lot of association with other healthcare, and we help each other. We learn that we don't have to depend from the government, we can do it ourselves. We have our staff is a volunteer in the task force for emergency, so we don't have to push the people to do it. They wanted to do it because this is a primary healthcare center, and our objectives always, and our principal objective is to help patients and underserved patients, people who don't receive the same quality of care in other places because they don't have the insurance that is private. We don't care about that. They give them top of the quality in healthcare here. With our association, especially with direct relief, they give us a lot of stuff to food, medication, extra medication for the patient. So that's how we work the majority of our natural disasters and non-natural disasters here.
Great. And then Ivan, what about the state of California as far as emergency preparedness resources for folks living with diabetes?
Yeah, so I mean, health centers, again, some offer home delivery and medications. Others work with commercial pharmacies who also offer home delivery. or have established MOUs with transportation services, either for transporting patients to appointments or again delivery of medications. Working along with the active outreach program to reach out to those patients in times of these emergencies. PG&E, which is a Pacific Gas and Electric company, also has a program for those that qualify financially that would help support for backup generators, which is important for keeping your insulin refrigerated when the power goes out. And then also some health centers have their mobile units or mobile clinics, which they leverage during times of emergencies and drive out to shelters or wherever it is that these patients are, and often have a supply of insulin on hand to use during these times of emergencies. As I said, sometimes patients aren't able to evacuate or leave their homes with them. And one of the things that we really emphasize to them, especially during these times, and those providing these services within their mobile units, is the collaboration and the support from the national partners. As Eunice said, AmeriCares is one of them that we work closely with. I'd also, and they're national or international, I believe. Another one that, other two that I would recommend also looking into, if people haven't heard of them, are Healthcare Ready and Direct Relief, again, also providing medications, medical supplies, and cash grants in times of disasters.
Great, thank you. So we have a little less than 10 minutes. I know we've had a couple of questions come in. We did have a follow-up question for our panelists that I just didn't make one of these prettier slides for. If we could go, Cindy, past this one, and then, yep, we can stop. Oh, sorry, before the question slide, we had asked our panelists just via email around how the pandemic specifically, so a public health emergency, may have changed any process, policy related to emergency preparedness and planning, and Eunice put together this slide. So I just wanted to give her a moment to speak on it and then let our other panelists quickly mention if there's anything else they can think of, just acknowledging the impact of the pandemic specifically and how that's created, an extra layer of complication potentially for the other types of emergencies that your health centers may be facing. So if Eunice, you want to go through this slide quickly.
Absolutely. So has the COVID-19 pandemic changed your health center emergency planning process or policies? Well, we've had to screen the patients before coming to the center. So even over the phone, the isolations room were available in all of our departments. Not only did we have medication delivery, but also push for the 3-month supply for all of our patients. Obviously, they needed insulin, medication drive up. Even when people just didn't want to do the phone or the app, they would just still come up to the centers, even though the centers were not completely 100% open, because we were pushing for telehealth. We had the medication drive up, diabetes drive up for A1Cs, and where they got the A1Cs done, also their foot being checked, improve the parameters to stop the spread of infection, healthcare associated with infections, right? Like disinfecting equipment constantly. We use the plexiglass barriers at all stations where patients usually were seen, or we use proper PPE, masks and gloves, and also the foot control or traffic control of our center. Vaccination requirements for all of our employees, contractors, and volunteers was put in place. We engaged staff in infection prevention surveillance, hand hygiene. Environmental care was more aggressive in its cleaning process and disinfecting processes. Handheld sanitizing foggers were put in place in all of our departments where patients were seen, including the medical, vet, and dental, and improving contact tracing with communication within all centers, and of course, the Department of Health.
Great, thank you. Yeah, that's quite a few things that have certainly been impacted. Dr. Silky or Ivan, do you have anything you wanted to add around just the general question about COVID-19 and its impact on emergency planning processes or policies?
we almost did the same, and we changed our clinical infection control protocols. We have to do that in a week. I still remember. And the other thing that we did, we have temperature machine in the entrance of every clinic. So the patient have fever, they go to but we don't have an isolation area in all of the department. We have only in the emergency room. That's the only place we will put the patient in isolation.
Great. And Ivan, anything else you wanted to mention?
Yeah, I mean, Eunice covered a lot of what I've been hearing as well. I mean, the only thing I would add is just the incorporation of telemedicine.
Sure. Yeah. And to your point, Ivan, I think that so many barriers, as we've talked about, can worsen situations for patients and health center staff, and telehealth, telemedicine is that one area, despite there still being some barriers. Want to be mindful of technological literacy and access and all of that. But for some patients, they were able to see an increase in access to care through that. So I think it's a really important consideration. All right, so we have 5 minutes left. We can go generally to the question slide, Cindy, but I do want to mention before we get to the very end of our hour, is that again, we have an evaluation and CEU link. I believe it will pop up for folks. I think that Kara is putting information in the chat, which is wonderful. Yeah, there's a link there. I believe you'll be able to access it when you leave the Zoom as well. We'd love your feedback in general. It helps our future programming to be better tailored to your needs. Also, you'll need to fill it out if you are eligible for CNE credit and want to receive that. But again, we have a few more moments, but wanted to plug the evaluation link in case anyone needs to leave early. We have a question, part of which was addressed, but I want to look at the Q&A and ask specifically around, do any of your health centers or PCA have any specific resources to reach farm workers specifically? And we'll start there first. And if you do work with farm workers, is there a different sort of approach, outreach to that population living with a chronic condition than your general population? So I don't know, any panelist can take that question if your centers work with farm workers.
Hi, we do work with farm workers. We all of their services in the mobile unit. We go to the farm, and that's where we contact the patient. Even the medication and everything is delivered there to the patient, so they don't have to come to the center.
Wonderful.
It's a face-to-face encounter with them.
That's awesome. So yes, this is Eunice. We do have 2 centers in Miami-Dade that are located right within the migrant communities residents. And so we've been able to bring the medical mobile van also to the nurseries. And so the process is no different for them. You know, we just want to make sure that the outreach workers that are actually, you know, communicating, having an encounter with the migrant communities are ones that they're comfortable with, that they know, and that they speak their language or their dialect.
Sure. Yeah. Fantastic. Thank you both for that. Want to just be mindful of the time. We have another question in the chat. This is the complicated question that we may not get a ton of time to really dive into the specifics, but it is important. It's a layer of consideration when it comes to the COVID-19 pandemic and folks living with diabetes and how we're communicating with them, engaging with them on their health during an emergency, around how did any of the panelists or the corresponding health centers handle or interact with patients with diabetes who didn't want to receive the COVID-19 vaccine, potentially because of stigma, misinformation. Is there any panelist that wants to tackle that question quickly? We only have a minute or 2 left in the session.
So what we participate with Florida SEAL, there's a lot of education that went on with us to be able to, you know, not only depend on the doctors to give this information to their patients, but also with the outreach workers and ambulance services had to really do a lot of education and training to be able to talk and give this information to the residents, especially the migrant community. And so it was just constant education, just, you know, and for them to see, listen, you know, if my neighbor got it, if my cousin got it, you know, and it was just a lot of hearsay, you know, so it was really more of like, you have to make the decision on your own and just provide them education and continue with their care, you know, and let them make that decision.
Absolutely. And I see our
Couldn't
panel.
really make them do anything, but just a lot of education for them, just let time pass by until they feel comfortable with what they saw, what we were doing in the community. It wasn't only just the FQACs, but a lot of other agencies that would just come and support. And so that's how you will win them. Because it wasn't really about them being scared for the vaccine. It was more like they just didn't know everything that was going on. It was just too much at the same time. And of course, people were suffering because they couldn't go to work. There was just other things that were just happening. It was just the health, the vaccine or the COVID wasn't really something that they were concerned about.
Sure. Yeah, thank you so much. And I see our other panelists nodding, so I'm going to take that as agreement. We're just about at time. Cindy, if you want to quickly just go through, again, the evaluation link that's in the chat, it'll pop up for you. You also probably should receive it in your email. Our final session of the NLS is on Thursday. So if you would like to come back for another one of these webinars, it's held at the same time this Thursday, the 15th. Can register at chcdiabetes.org. We thank our wonderful panelists. Once again, I think the next slide has their points of contact. Everyone should have received, or you might have seen in the chat box, a link to the slides. You'll receive that via email along with the recording later this week. If you have any questions for us going forward, you can certainly contact any of our NTAPs. And again, you can contact our panelists directly if you'd like to. We appreciate everyone's time today. Have a wonderful rest of your day and take good care.
Thank you.